so everyone can hear you.
Thank you very much. Thank you, Nick, and thank you, Simon, for your positions in the footwear industry and what we're trying to do. I think having a debate on footwear and having a debate on how to better treat our patients is really needed. We are looking at two different directions, either minimalism or the traditional, but sometimes we forget the third area that we may look into is maximalism. Now, maximalism is being used by the O&P industry, and Nick put up the picture of the spring blade lady showing 92% energy return during her mid-stance gait. If we start applying those principles that the O&P side is using, how can we continue with a two-sided debate and not a three-sided debate, which would include maximalism, including the composite materials, spring lever systems, systems that actually engage more engineering thought than necessarily just barefoot running and foam shoe run, because that's really where the debate stands. And I humbly ask, can we not, as a group of physicians, start adding maximalism and researching maximalism to add it to our treatment regimen?
I'll start with that. Well, first of all, in regards to maximum, I have my theory on why they're gaining popularity. If you've ever ran a Hoka 1-1, it's no different than running on wrestling mats.
I'm not considering Hoka 1-1 maximalism. That's double thick shoe. We're talking composite materials that return a vast amount of energy return within the foot that give Simon the stability that he's asking for and allows the runners either to run heel strike or toe foot.
Okay. In my opinion, and according to simple physics, you have to eliminate heel striking to have this discussion. So throwing out heel striking means you're looking at synthetic materials to absorb shock and increase elasticity when it's already there in the Achilles tendon. There's two things you need to look at in this debate. If you're trying to reduce injury, that's one thing. If you're trying to speed up a runner's or increase their ability to run faster, you can't do that. Because that would be like me saying, put on a pair of rollerblades. You'll be able to finish faster. So the point that I'm trying to make is, you can't rely on synthetic materials to increase your elasticity or to improve your gait.
You just showed a picture of a lady doing that, though.
Because she's missing her foot. And we're trying...
She's running on a composite blade.
I have to remind you, though, that her foot is gone, and we're trying to put her foot back, and we put it back in a midfoot strike position.
I would just like to comment just a little bit about what we're trying to achieve. If you look at the picture here, not only are we working with runners, we're working with football players, we're working with track people. We're using, as you just described, composite materials, lightweight materials that allow the foot to engage the ability to have proprioception. We're doing sway analysis before we start on their running programs, beside their computerized gait analysis. And using these lightweight materials, we're looking for, as Nick just mentioned, that spring element back into the foot, proprioception, but stability. So basically what I'm saying is we're looking for a compromise situation here. If the individual wants to run in a minimalist shoe, if we can look for that, what we call middle ground, lower the heel, but still afford stability and biomechanical control for those individuals who need it. And we as podiatrists, as biomechanical specialists, that's our job. That's what we're here for. That's what people come to see us for, so that we can evaluate them and determine who needs that control. Or do we put them in a shoe and say, go at it, and then they come back in with either medial arch complaints, plantar fasciitis, stress fractures, or whatever. I think we need to move on to the next question.
If somebody does,
we're going to move on to another question.
Change your mind.
No?
Okay.
Go ahead, sir.
I found it very interesting about the talk about hallux rigidus. You mentioned hallux rigidus in a barefoot shoe or minimalist shoe. I have patients who I do arthrodesis on and I tell them to run. Should I not, but shorten their stride, should I not tell them to not wear a minimalist shoe? Should I warn them against it? It seems like shortening the stride would make a difference. So just, what do you think?
Well, and this is why I don't like to rely on shoes and running. You have to, what we fail to look at in a lot of runners is there's training patterns and their form. He mentioned the propulsion phase of gait, and we were all taught this in biomechanics 101 in podiatric school, and I no longer believe in that when it comes to running, because there is no propulsive phase at the great toe joint if you midfoot strike, in comparison to if you heel strike. So what I'm saying is, if your foot lands below the center of gravity in a midfoot strike, that propulsive phase, you do not need the 65 degrees that we were all taught. Now again, I'm saying this anecdotally, but if you slow frame cinematography, watch runners, that midfoot strike versus heel strike, if you're heel striking on an outstretched limb, if it's below the center of gravity, it's okay. It's still not right, but it's okay. If you're heel striking on an outstretched limb and your foot hits the ground, you now have to get this entire body in front of that foot that's on the ground, because running is a single-legged sport, right? So your body has to now move forward. You need the motion at that great toe joint. So in what you're saying, yeah, it's going to be a problem. You might want to resort to that type of shoe. If you change the runner to a more midfoot, shorter stride gait, then it's not as important.
Basically, just to answer very, very quickly your question, if you ever watch a marathon runner in the later stages of the marathon, and I've been there myself, what happens? We start with a nice heel strike, usually, for those who are really well trained. Then they go to a mid-stance type of gait, a mid-stance strike. And then if the marathon continues in the latter stages, what are you doing? We're basically forefoot striking. The problem is, if you looked at the research studies, you saw shin problems, you saw Achilles tendon injuries, you start to see jamming of the first NP joint, and I would suggest, or I would challenge our audience who've been treating runners for years and years, how many hallux limitus rigidus cases do you see after so many years when they come in and they can't propulse, and they have pain, and they can't do lunges, and they ask you, what am I supposed to do now? A first-rate cutout, a Morton's extension? Are we supposed to biomechanically correct them, or surgically chilectomy them, or fuse them, or joint replace them? But the key is, you still, and I disagree here in this case, you still need that propulsion of the first NP joint. If you get that elevation, that med primus elevatus, and you get that jamming of the joint, you're going to develop synovitis of the joint, you're going to develop breakdown, wear and tear of the joint surface, and you're looking at either joint replacement or fusion at some point in the running career of that individual.
Thank you. I just have one question on part of your presentation. You were talking about the raised heel of the shoe, and you're comparing it to creating an Aquinas, and said that that would cause more pronation, I believe you said.
Well, that's what Ruth said.
Well, the presentation you made, you didn't take into, I mean, in an Aquinas situation, there's no, the shoe now becomes the ground support. So when you're elevating the heel in that situation, are you truly creating an Aquinas? Because certainly, this is anecdotal, but in practice with patients, particularly females that have plantar fasciitis, they're certainly more comfortable in a heel than they are going barefoot. And my assumption would be because that elevated heel is taking the stress off of plantar fascia, which would be counterintuitive to what you said about a running shoe with a raised heel actually increasing pronation because kind of creating an Aquinas.
Well, I guess the point that I'm making with the heel is there's no scientific reason to put a heel under a shoe. And if you look at if you look at an image of someone standing, and this is a dress shoe that I wore today, there's no heel on it. And the reason I'm wearing it is because if someone could tell me the need for a heel on a shoe other than to have my slacks not hit the ground, I'd gladly accept it, but it doesn't exist. So when you put your foot like this, even if there's cushion or if it's rigid, you're going to plantar flex the ankle. If you're going to stand in a neutral position according to anatomy, your whole body would have to move forward. With the counteract those forces, you will lean backwards. So I'm not saying you won't reduce the symptoms of plantar fasciitis with the heel. You probably will, but this brings up a ton of other topics, but what I would like to say is that acute cases, the heel may help. Chronic cases, you need to change their way of functioning.
Thank you. Okay, we're out of time. Certainly want to thank both of our speakers. And it certainly is going to be a topic. Okay, we're going to move on to our next topic in the